pays off.
Yeah, it was. Did you keep it under 1,000 calories per sitting, Guy?
Oh, I thought you were going to say per course. Per course, probably, maybe not per sitting.
Maybe.
We always get up and try to exercise do a turkey trot and stuff. So on Thanksgiving Day, so at least we started out at a deficit. But
makes you feel better, huh?
It sure does. Well, everyone, we welcome you to Dental Sleep Treatment Flow done properly and efficiently. We hope by the end of the night you'll know some steps that you didn't and how you can get dental sleep in your dental practice. That is, we thank you for taking your time to spend the evening with us. We do a lot of these webinars about every other Wednesday night. I think we have another one coming up in a few weeks we'll talk about, and I think this is one of the reasons we do it, because dental sleep is important. We care about our patients, so we do oral cancer exams. Rich, you still do oral cancer exams on your patients, I guess, right?
Yeah, I look in their mouth every now and then. But when we see something like this, I think, I've heard you say it before, Guy. It's like you wouldn't just say, hey, that looks kind of nasty. You probably should get that checked out, and then say, I'll see you in 6 months, and we clean your teeth again. No, you'd be a little more serious about it. I think that's part of the problem that a lot of dentists have, guys. They don't create any sense of urgency in their patients about how important it is to treat sleep apnea.
Yeah, and I think that really comes a lot from the dentists themselves. And the reason I believe that that's true is that we talk to our patients, our dentists, and they screen their patients for oral cancer. And usually when we do a lecture, people hold up their hands. Yeah, we found 1 last year, 2 last year. Well, that's about right for the prevalence of, less than 0.001%, that is. If we were doing our job, how many sleep apnea patients would they be finding? Because 1 in 5 adults has apnea. So when we do our courses, in-person courses, and we ask the dentist and the dental team to raise their hand if they've screened their patients for apnea, and if so, how many they've found, and usually about the same number of hands come up or less, which has to mean that we're not looking as well for it, or that we're maybe not having those conversations where we should, because 1 in 5 adults has obstructive sleep apnea. If you're going to take your time to talk to your patients and you care about their health, we need to start looking for this.
Yeah, is it on your radar? Well, hopefully it is, because you tuned in tonight to listen to us talk about it. So, we really think, Guy, that the curve's kind of going up like this. Certainly you can't hardly pick up a journal today, whether it's a dental journal or a cardiology journal or ENT. Almost everyone has something on sleep these days, and we're learning more and more about how all of these comorbidities are related and all that other stuff. So again, we're happy that you joined us tonight, and we hope that you pick up a couple of pearls about how to treat your patients better.
Yeah, and like you mentioned, you can't hardly turn the news on or look at the paper. And one of the things we'll talk a little bit about today is dental sleep patients, looking for them in your practice, screening your patients. And when I put this article up on the screen, oftentimes we say, look, the Federal Motor Carrier Safety Administration screening patients. That's a department of the DOT that regulates commercial drivers. And most people say, well, that's a pretty good idea. If they're commercial drivers out there driving and they may be falling asleep at the wheel, they should be looking for this. Well, I agree, but we should also be looking for this. If we were doing our job, maybe the DOT and the Federal Motor Carrier Safety Administration wouldn't have to be screening all their drivers for obstructive sleep apnea.
Well, I think that's part of the issue, Guy, though. Who's screening them? Where are these people? So that's, we say, a lot of people in the country have been to see the dentist. Now, sometimes it's because they got a big hole in the side of their tooth that's draining pus out. But, a lot of these people are walking through our doors every day just to get their teeth cleaned. I'm just coming to get my teeth cleaned. I like to relate the story, Guy. I've been out of school 3 months, and I'm giving a guy a shot, a mandibular block, and he's asleep and he's snoring. And you know what went through my head? Man, I'm good. I'm giving I didn't even think he was probably going to be dead next year, from sleep apnea. But yeah, again, a lot of people go to the dentist. We are in a prime position to see these people. We've got to start asking questions. We've got to start looking at this, because nobody else is doing it.
Yeah, in the past, if really it was left up to the physicians, and the physicians, first of all, they didn't identify that many patients. But let's say that they did. They said we've got 10 patients. They say you're at risk for having sleep disorder breathing or obstructive sleep apnea, some form of a nocturnal sleeping problem. Well, what would they do? They would say you've got to go down, spend the night at the sleep lab, and stay away from your family and stay in a strange bed and spend several $1,000s. Rich, when we do these live courses, I ask how many of your patients you think would do that, and the number is usually less than what we estimate it to be here at 5. We're lucky when we get 5 of those patients to actually show up at the sleep lab. What will happen? Will they mostly have sleep disorder breathing? Well, most of them will, because what we do know is if we do the right questionnaires and we screen our patients adequately, the people who identify as being high risk will, in fact, have some form of sleep disorder breathing. Now, what's going to happen to most of these patients in the past, Rich? We've been doing this. We've been looking at sleep apnea. Give them a CPAP. How many will actually wear it long enough for Medicare to say they can keep it? Because Medicare kind of set the guideline. That's 4 hours a night, roughly 4 nights a week.
5 nights, 4 hours a night, 5 nights a week.
5 nights a week. Yeah, maybe half of those will qualify in that first 3 months, and that's been, I think, pretty generous there. That 50% or better will qualify. But if you look at patients 2-3 years later, how many were well their CPAP every night, all night long? It's down to 1. And these are our opinions for the most part. But I think most of the time when we talk to groups of dentists who are doing dental sleep or even physicians, I don't think anybody argues that we're way off on these numbers. Do you think we have an opportunity, Rich, in dental?
Well, you just said it, Guy. 1 in 5 is walking through your door. So we can ask the same types of questions and screen. You're a little overweight, you're snoring. Hey, you fall asleep while I'm giving you a mandibular block. You just said, man, you get lost on the way to the office here because you can't think straight. If we do that right, we're going to get most people to say, well, I get to do it in my own home. How much does it cost? Does my insurance cover it? Just a few $100 at most. Yes, your insurance does cover it. So we get most of those people to do it.
Yep.
They don't have to go down the street. They don't have to take the night off away from their family. They don't have to hook up 100 wires. They only got to hook up a couple. And if we're doing our screening correctly, most of those people that we send for the sleep test are going to have indeed some kind of sleep disordered breathing. Now we're going to make them a mandibular repositioning device, And the difference between CPAP and dental devices is CPAP is an effective therapy, but we know that most patients simply won't wear it. Even the people that like it, they don't want to wear it. But most will wear a dental device that we make them. And, even though we're not quite as effective, we're still lowering that apnea load and we're treating it. And I mean, Guy, if you even took the dental side and you cut it in half,
right,
and you doubled the medical side, we're still doing as well, if not better, than the medical model.
Absolutely. And I know this may not be news to some of you, but some it is. And part of our job and our goal, why Rich and I started Dental Sleep Solutions and DS3, was we wanted to help dentists help their patients. We were actually kind of upset, I guess would be a nice way of saying it, about the way the world was, the way that all these patients were going undiagnosed, untreated, and we kind of made it our mission to solve that as the best we can, or at least help. And so I'm the guy on the left, Rich is the one on the right, and we've been doing this for pushing 20 years each now. I think 17, 18 years apiece, and we've done thousands of devices. We certainly don't know everything, but we certainly know more than most, and we can help you do dental sleep. That's what we do at DS3. We help with education, coaching software for what we call the 4 pillars of dental sleep, which are screening, testing, treating, and billing. I see some questions coming in. We're going to answer those as we go throughout the night. We'll make sure we stay on and answer the rest of them. And if you have more questions about dental sleep, you just want to pick our brains or ask specific questions, just type in free consultation tonight, and one of our dental sleep experts will get back with you, set up a free consultation to answer any questions from which devices to use to what do you do about Medicare, and a lot of the things that we may not have time for tonight. And I think you'll get a lot out of that. We will be doing another one of these in a few weeks, probably the last one before the new year, and then we'll start back at the first of the year. And what this is going to be is a little bit more about dental sleep implementation, but a little bit do's and don'ts is one way of putting this. There's some questions that come up, Rich. Do you ever hear that? Does the ADA, who says I can do this and what I can't? What do they say about it? There's a new position paper that came out in October, I think it was. Wasn't it?
I think it was very recently, yeah. So, the powers that be, these are guidelines. It reminds me of the Pirates of the Caribbean movie guy, where he says, well, it's not really a law, it's more like a guideline, whatever the parlayer was, or whatever, something like that, It makes me think of that. And, as dentists, we can't diagnose sleep apnea. Just get that through your head right now, okay? Don't even think about it. Don't do it. But we can certainly screen for it. We can help facilitate the sleep test. We can do a lot of these things. And we don't want this stuff to scare you off. You can save people's lives. Guy, most of the people, some of the people are still in the chat. So guys, let's try to move it out of the chat. The question box is really a little bit better. So if you have any questions, put them in the question box rather than the chat. It works a little bit better. We're trying to monitor both of these, but it works a little bit better if we do it in the questions box.
Yeah, it's a little more room to type there for everyone. So again, that'll be in a couple of weeks. We'll remind you of it again here at the end of the webinar. And we preach this all the time, that if you want to help your patients live better, live longer, and make your practices more successful with dental sleep, all you have to do is have a system and team members to help you screen your patients. You have to have ways of getting your patients tested. You have to have ways of getting your patients treated, and then you got to be able to bill for these procedures. And we talk about how long this takes. And when I first started doing this, prior to me meeting my good friend there, Rich Drake, and I was trying to do this in between root canals and crowns and everything else you do in dentures, and it took me hours of time because I didn't have a system. And what we did when Rich and I got together is we took a lot what was in Rich's brain and a lot of my organizational skills and the fact that I had to be a little bit more efficient than Rich because I had a busy dental office. Rich spent more time fishing than I did back then. No, he's working 6 days a week, I think. But we found a way to make you go through these steps in under an hour, we'll say. I mean, I know Rich and I spend less than an hour most of the time with our patients, and we're not saying that because we're giving the patients a short end of the stick. We say that because we're efficient in what we do. We have good team members who do their jobs.
We have a system.
Have a system.
Have a system for how to do this, and we delegate. But there are a lot of moving parts, Guy. And what happens when when one piece of the chain breaks, the chain's no good. So you don't have to reinvent the wheel here. We keep saying that to dentists all the time, and that's why we have a lot of people using DS3, and we help you do this. But you got to start with a patient somewhere, right?
Yeah. And you think there's some in this crowd? These look like most all adults there as I look at it. Just to cut that into fifths, and that's pretty conservative. I think a lot of people are there's some evidence even saying 1 out of 4 now. I mean, you cut that page almost in fourths, and that's how many of that crowd right there has apnea. And all you have to really do, and I mean, you can go have dinner or something, because this is probably the take-home message, is that if you believe in this and you realize this is my job, if I don't do this, no one else will. And if you're organized, you will be able to help your patients through the rest of them. It's as simple as that. There are systems that we're going to go through with you tonight to help you, put this into your practice. Rich, we've been using this slide for quite a long time, but I think I don't see any reason to change it, because those right down there, it's not even these up here, are they? If you can see my pointer, it's these. There's a bunch of these in the basket already in most people's offices, wouldn't you think?
They're walking through the door every day, just like Guy said. I would say, Guy, in San Antonio, we're a little bit fatter. We like our Mexican food down here, and I think there's days in some parts of the city in San Antonio where 1 in 2 of the patients coming through the doors has sleep apnea. So this is the low-hanging fruit that we're talking about. You don't have to go out there and buy a whole bunch of radio, TV time and stuff like that. Just start screening the patients in your own practice. And if you're not, that's a good way to look at it, isn't it, Guy? Just money flying out the window.
You're losing money if you're not doing this, and that's hopefully not the only reason you get up and go to work in the morning. But these patients need your help. 1 in 5 adults, as Rich said, and really the low-hanging fruit. There's patients in your practice who have been diagnosed who aren't wearing their CPAP every night, all night long. There's dozens and dozens of patients in most adult dental practices. So there's a lot of ways to come by them here, Rich. I think we're going to go in a little more detail on some of these in future webinars and our symposium, I think. You're talking about marketing there, right, Rich? I think, and I'm talking about a little bit more of the talking with physicians.
Yeah, and I'm going to start to share some of my stuff with all the TV time and radio time and, internet and stuff like that, the external marketing stuff. So, man, it takes a long time to put that together. I need to hire a guy to come over to my office. He's the most organized guy I know, and get some of that stuff organized for me. But it does generate calls, and I am going to talk about that. But, we've got to identify these people somehow. Guy, how do we do that,
Yeah, and we can do ads, we can talk to physicians, but again, starting right in your practice. And this is how I started, is Rich and I worked on this list, and so I just put that out and put it on my desk, and every day I looked at it, I put it in my operatory, said, if the patients have high blood pressure, well, then they're at risk. Why is that? Well, there's a study that I know of that shows 30%, one that shows 37% of the patients have hypertension. And you could go through these. I don't have to read them all to you, but you just look through those and you can just go, that patient's at risk. This patient's at risk. Oh, this next one has a big neck. Yeah, and when you get more than one, yeah.
Guy, I got to tell you, this morning, this just actually happened this morning. So we get this old couple come in, and the man is here for the appointment. He's doing our DS3 portal because they couldn't get it to work at home. So they sit down at the computer in the office there. She's filling it out for him.
Okay.
We go to do the consult for him, and she goes, I was sitting there doing that questionnaire, and I kept saying, well, that sounds like me. That sounds like me. So next thing you know, we're getting her a sleep test too, and we're making him a dental device. So
yeah, that is, it's just so common. All you have to do is open up your eyes and start looking for this. I know it's harder than that. We try to make things in a system, and I think the biggest problem, people go, oh, that guy's got a big neck. Oh, you snore. Here, let me show you a dental device. We jump down to the treating part because that's what we want to do as dentists. And the hard part for dentists is the difficult steps in dental sleep are not the treat. We're used to that being the difficult part of our jobs, and really it isn't. We have to have a system for this. How do you find these patients? And then what's the hardest step? Rich, you've got to have people in your office to do the next one, or you've got to do it yourself.
Yeah, I mean, sometimes, it's that place where my wife says most men live, denial, that river where most men live, you got to get them to acknowledge that they have a problem. What do you mean? I'm 50 pounds overweight. I'm tired. I fall asleep at the stoplight. Doesn't everybody? No, not everybody does. So you got to identify them. You got to get them to acknowledge it. Now we got to start them to walk down this path where we got to get them tested. So again, Guy's talking about all this stuff that has to happen before we start talking about that dental device.
Yeah.
Look, we got to figure out some things first.
Yeah, and we do a lot of webinars. We can get into more detail on each of these. If you type in consultation, we can point you in the direction to learn more about this. We can also go over it with you. But the acknowledge part and having someone to test is a big part of the puzzle here, and that really comes down to verbal skills and having a system for testing. If everything goes well and they have apnea, well, it's not that we hope they have apnea. If they have apnea and they got tested, before we treat them, oftentimes we're going to also need a system in there to discuss how much it's going to cost them. And many of these patients, even though they're your dental patients, may want some medical help from this, because the other treatment, which is CPAP, they pay for, and they'll want you to manage the medical billing for them as well. So this is the screener you were just talking about, right, Rich?
I love that thing, man. Guy put his brain together and he created this kind of thing. So we can make this as easy as a tablet that has internet connectivity. You just log in. You can even delegate this to staff. Like Guy said, your hygienist, your patient coordinators, somebody that says, hey, let's look at this. And it's a very simple questionnaire. It takes most of our patients, Guy, 4 to 5 minutes to do. That's all.
Yeah, we hand it to them and they go through it. And at the end of the day, I think the thing I like about it is when they do have a problem, it says this severe risk on the tablet like this. And that does something that I like. I like to engage my patients. I like them to ask me questions about treatment, about health issues that I want to talk to them about. It's much better than just say, hey, you're at risk for this. They're asking, it engages, and our system makes that a lot easier. There's paper forms and a lot of other ways of doing it, but I really think our screener really just streamlines it and involves the patient much more than some informal piece of paper you may give someone. So what's
Guy, I want to add too that tablet, that computer says you're at severe risk. that just means more than a piece of paper or something. Like they think it's smarter or something. I don't know what it is, but
yeah, I agree. When they're I'll even back up. When they see this is the best part about our system for doing that. It takes them about 2 to 3 minutes to fill this out in the reception area, and then we have to have a system for talking to them. We probably don't want to have that conversation at the front desk. We probably want to have someone to go over the results with them, and we certainly don't want to say, it looks like you have apnea. That's one of the do nots over there. We want to say, look, you're at risk here. We're concerned about you that you have some issues, and you have to go through what those issues are, whether it's hypertension or snoring, and we need to figure out what's going on. How would you like to evaluate your breathing? You want to go down to the sleep lab, or do you want to spend the night at home with a little measuring device on? It's up to you. You taught me that, Rich, and I think that's probably the most powerful verbal skills there. You just give them the two choices, and most people are going to choose to go to have it.
You're right. You don't ask, well, guy, do you want to get a sleep test? No, not really. I mean, you go, would you prefer to go to the lab, or would you prefer to do a home sleep test? I think that's a good way to put it. So now we're finally down to where they have had a sleep study and they've been diagnosed, right? So now what do we do?
Yeah, we've got to get a sleep test. We got to have a plan for that. Not quite. Rich is ready for his tacos or something there, but we've got to get to the test first. We're ready to get a diagnosis at this point, and this is where things have become a lot easier. One thing, I guess I'm turning into a grumpy old man. I say, you don't know how good you've got it, to our 11-year-old a lot, and I say it to dentists that I'm training. And Rich, when we started, the testing was one way. You go spend the night in the sleep lab, period.
There was no other option.
There was no other option. The patients, if they went, they would never come back because they'd get a CPAP regardless of their level of airway problems. And now we have choices. We can still send them to the sleep lab. This looks like much fun to me. I mean, they do have nicer ones, but does that look like you're going to get a restful night's sleep there, Rich? If that was you back when I saw you.
I've heard all kinds of stories, I mean, and guys said before, I've heard you say, Guy, an in-lab test is a more accurate test of a less typical night's sleep, and a home sleep test is a slightly less accurate of a more typical night's sleep. So everybody prefers to do this in their home. But again, sometimes we have to be smart about this. And, I think if you ask me, Guy, well, which sleep test would you want to prefer? You know what I'd probably say?
Yeah.
Which one does my insurance cover?
Yeah, that's true.
Sometimes that it's as simple as that. And we go, well, but again, we've just got to start this process. We screen them. We've got a system now for how we're walking that patient. That's why I love that slide you made, Guy, where you're walking up those little steps, towards getting these patients treated.
Yeah, and the home sleep test, we'll talk about during our next webinar about how you can do this and what are the laws involving this, what are the political opinions about it. We're going to dive into a few things like that in our next webinar. But just at a high level, today you have two options. You can go to the sleep lab, which a lot of patients don't want to do and would not prefer not to, and most insurances don't want to pay for, back to your point. Or you can go get a home sleep test. If you do a home sleep test, you can do that by going to a physician or a sleep lab who has it, going down to number 3. There's times where a dentist can hand them the sleep test, and then they can get this information given to a physician who can give them a diagnosis. And now there's companies we work with who we can order a sleep test from, who will just mail it to the patient, and the patient will mail it back. And again, if we left you a little questions about when and where you can do that, tune in next time and we'll go into that. Also, you can type in consultation. We can answer those questions through DS3. We make it pretty easy there, Rich. I mean, we wear that button out in my office. I don't know about you.
Well, it's just a click. Again, you got to be smart about how you do this, and we're trying to walk this patient through this. But, sometimes, Guy, we talk about the hurdles to doing this. And before, like you said, you're telling Nicholas, man, you know how good you have it, kid. And we tell that to dentists now. We used to have to beg our patients to go, to the sleep lab. I mean, I remember seeing one guy every 6 months clean his teeth for 4 years. And I said, man, you got to go get a sleep test. You got to go, and he finally, 5 years later, he does it. And now we can make it a whole lot easier.
We absolutely can. And what that equates to is not just us making more money or, adding to our bottom line. It's helping our patients. These patients weren't getting diagnosed. They weren't getting identified. They weren't getting diagnosed because of the hurdles. And we're trying to lower the barriers for the patients to get in. I see still a lot of questions are coming in. We're typing those answers. Some of our expert teams answering some of them, and we'll get to all of them before the night's over. So keep them coming, and we'll be happy to answer all of them before the night's over. Assuming, Rich, we did the screening, they're at risk. We identified them. We got them acknowledged. The patient said, yeah, I get it. I may need to have my airway evaluated. It comes back. They have apnea. What level of apnea we can talk about next time a little bit that's best treated with a dental device. But assuming they fall into that category, we're going to need to treat them now. They say, yeah, great. I don't want a CPAP. I want a dental device. The treatment itself's easy. The management of the treatment required us to invent DS3 and some systems here, didn't it? I mean,
yes, it did.
How did you do this before we had DS3? You had a lot of dead trees in the office.
Oh my gosh! You just can't believe. I don't know how people do it without that. And I know that sounds self-serving, guy, because we own DS3, but I honestly don't. And we hear dentists all the time who work with us that say that we've just given you the sidelines, and we've given you the tools to organize this and make the system work. And it's really, we've made it as simple as you can make it, and how we track these patients and what we do, and we have places to put sleep tests and subjective symptoms and all of this kind of stuff. And if you're new to this, I can see how it would be a little overwhelming. But when we break these things down into these steps, and then we're trying to help you through that, it's really not that bad. Guy, if you can figure out how to do a root canal, you can certainly figure out how to do this, don't you think?
Yeah. And to be fair, you can do this without DS3. We did it for years without it. It's just a lot of paperwork. We want to give you some value for tuning in. Take a screenshot, take your phone out, take a picture of this. This is what you're going to need to have systems in place to treat your patients. I'm going to go through the steps, but you got to have ways of tracking all this. And it's just kind of a paperwork jungle that you have to navigate. And that's the only hard part about the treatment. I mean, we don't even talk that much during these webinars about, taking impressions or taking the bite, because compared to doing
we know how to do that.
Yeah, doing a single crown impression is far more complicated. So, again, we're about halfway through the webinar, so we do want to mention again that DS3 that's what we do. And if you have any questions, I think you'll be happy you called. We'll set up a time to answer any challenges you have in dental sleep, and we can talk to you about how we can make your practice profitable and much more enjoyable. We'll give you our contact again at the end. Goals, Rich. Do you talk to the 3 goals of your patients?
Well, I love your first one there. I mean, if CPAP had started 30 years ago with that being their #1 goal, Guy, that we might not have a job because they never got past step 1. I mean, most of the people just can't wear CPAP. So yeah, you got to wear it. My job, I tell everybody, Guy, my job is to make it fit and to make it comfortable. That's my job. And your job is to tell me if it's not right. You can't come back a month from now and say, oh, I wore it a couple nights and I had a little sore spot, on this gum right here, so I didn't wear it. You're not allowed to say that. You're not allowed to do it. So #1, absolutely, you got to wear it.
Yeah, well, they're allowed to say it, but they need to call you and come in and say, I can't wear it, right? I'll make that clear.
You're not allowed to say it a month later. Yeah.
A month later. Yeah, let's make that clear. I mean, we want them, if it's not comfortable and you can't wear it, you come in. Because it's very, very, very rare that I can't make that type of thing go away. And that you can't either if you're even new to this. It's not a complex thing to adjust a tooth to get it more comfortable. Most people will wear the device. Now, why would they wear the device is the next question, or a CPAP? I mean, a lot of people just say, well, because they have apnea. Well, what does that mean? What do we care? And I think you have to consider every patient's different, and there's 2 reasons why people might wear the device. One is for symptoms, and the other is to decrease the number of apnea events they're having to make them more healthy, to increase their longevity and their health. And so if we're going to talk about success of dental sleep, we really have to start at the consultation and start by talking about what success means, both in symptom relief, or we evaluate that subjectively, and in lowering the patient's apneic index. If you don't know what AHI is, we'll get into that at other webinars, but it's the number of events an hour someone has. And so, you know what you said, Rich, I think it's kind of funny, just kind of occurred to me. You said we start here and CPAP doesn't. Where does CPAP start?
CPAP starts with, we've given you a sleep test, we've tested your CPAP works at this level, and then they hand it to you and they say, good luck.
Well, they say, I hope you feel better. I hope you feel better, and I hope you wear it. They'll go the other direction. We start with wearing the device, hope you feel better, and we're going to make you feel better, and then we're going to make sure that you're at the right health. They go the exact opposite. We kind of starting at
different ends of the spectrum there, aren't we?
And I believe it's some of the keys to our success. So when it comes to dental sleep, the actual steps of the treatment, not the screening and insurance and things like that. There's multiple appointments here. I think for dentists, I think this is probably the difficult one, because if they can't articulate what's going on with the patients and get them on board, they don't have patients, right, Rich? Well,
absolutely right. You're right. I mean, and we hear this all the time, Guy, that the dentist is the most concerned about that, and it's really the easiest thing. A lot of these other moving parts are the hard part.
Yeah, we'll talk about each of these little steps. So there's nothing complicated on here, from consultation to 6 month and then annual recall. We just walk through these steps and with our patients. And the first one, I believe, is the most important. We used to start with the taking impressions and which device to use, and what we realized, dentists don't have that big of a challenge with that in general. What they have a challenge with is a patient sitting there in a chair and they have apnea, and what do I say to them? They ask questions. How does that consultation go? And I think if we understand the goals of treatment, and we know that we're trying to help their symptoms, and we're trying to look at their number of events an hour they're going to have, and hopefully they're going to be a good candidate, and they may ask how much it is. If we have these three things in order prior to the consultation, even before they walk through the door, man, how efficient can you be?
Amazing.
Yeah, we'll go into each of those, but I can tell you, I used to not do it that way. They'd come in and all I'd have is a sleep test, or all I'd have is a questionnaire. And, we don't have much to talk about if we're not really looking at all the information involved. I think this is something, Rich, that you helped me with earlier on that was probably the most helpful. I got the first sleep test in my hand, and I think it was 8 pages long. And now some of them are 2 pages, some of them are 15, probably three or four on average. But I didn't know what I was looking at. I didn't know what was important on there. And even after I learned what was important, it took me forever to read through the test. Each time I'd see a patient, I had to go back and get reoriented. And you helped us come up with a system for doing that.
Yeah, you just need the key spots. We need AHI, RDI, LSAT, how long they below 90. There's a couple of things. And if you're new to this, again, don't let those things scare you away. We're just looking at how severe their sleep apnea is. And remember, a lot of times, Guy, people have a baseline 7 or 8 years ago. Then they put on 30 pounds, maybe their sleep apnea is worse now. So like Guy said, we used to kill a lot of trees, when we didn't have a system to put this stuff in and do it. Now we just have a better way of organizing this. So when we say verify that it's a baseline sleep test and that it's not too old, what would you say too old is, Guy? More than what?
More than 2 years here.
Something like that.
And we can still have a consultation just to understand that patient's apnea is probably much worse, and we may have to have a new test prior to beginning if we want medical insurance to cover any portion of that test. Yeah. So I'll hear you there, Rich. So the rest of the things on here, Rich hit, and basically we're just trying to extract that information out of the test. We put it up in the cloud on our DS3 platform so that we can real quickly at a glance see what this information is for the consultation. And as you'll see as we go forward, it will also be much easier to evaluate when we do follow-up sleep testing. You still there, Rich?
Can you hear me?
Yeah, I can hear you now. I lost you there for a second. So that's the objective part. So before we walk in, we know that have mild apnea, severe apnea, sleep disorder breathing. We know how many events they have. So we know where they are and we have an idea of where we might be able to get them from the objective. But, symptoms don't have anything to do with that half the time. Just because they have severe apnea, they may have mild symptoms or vice versa. And I think we probably spend as much time on this as any trying to come up with, how do we more objectively evaluate subjective symptoms. And I think we even had some few heated discussions about what to include in this subjective evaluation.
No, we never did. We never had any heated discussions. But it's kind of hard because subjective and objective, and it gets kind of, I always had a hard time with SOAP notes, guy. I don't know about you, but it's kind of weird that you measure something that's subjective, yet and then is it objective or not? So how sleepy are you? How bad's your snoring? Well, it's 10 out of 10, So we look at these types of things. I want to know this stuff, guy. How sleepy are they? So we use the Epworth Sleepiness Score. You can use the Stop Bang. You can use the Berlin Questionnaire. There's a number of ones out there. We use the Thornton Snoring Scale, the TSS. I love the chief complaint, guy. You know what I do? Every single consultation. I got my pen there and I'm doing my little cheat sheet while I'm typing in the DS3 and that. I say, okay, if I wave my magic wand here and I could fix one thing, what would I fix? And then I'd just be quiet. Well, I think it would be my energy level. My energy level is I'm just so tired all the time. Well, that's really two. I'm going to make number one, you're low energy, and number two, your tiredness, sleepiness. So I always try to get three. But, because now we go back and when we're looking at that subjective success and we're trying to put some numbers on it and stuff like that, we always have something to go back to.
Yeah, so this is that's really good. I've never said that. What's the one thing? I'm going to start using that. That's fantastic. These patients are putting this information in typically in a web portal prior to coming in for their appointment. So we're going to have this at our fingertips, but we still need to ask them these questions because they've got to clarify a few things, in particular, the chief complaint. And these are the questions we're going to ask each of our patients. We may ask additional questions, but we can at least have some consistency to our subjective evaluation if we systematize the subjective part of it. That was one of the things that was difficult. I don't even know if that's the right. Did I make that word up? Is that a real word? But
I'm laughing at that picture. I'm sorry.
I thought you were laughing at my abuse of the English language. But we need to have a way to make it repeatable in a system, even for the subjective part. So this is a screenshot from our summary sheet that we have in DS3, and of course this isn't a real patient. This is Pat, our patient, that's kind of made up, and maybe it's depending on the size of your monitor, you can see things, but at a glance we can see the chief complaint, other complaints. We can see CPAP intolerance down here. Are they wearing their CPAP or are they not? As we go further into DS3, we can look at all those things we just went through: Epworth, snoring, energy level, all the things that we just saw. And so at a glance, what a minute, you can get a really good idea. You know what their AHI is and all the objective information. At a glance, you know what their subjective information and concerns are. This used to take 15, 20 minutes if I'm looking through a 6-page questionnaire.
Yeah, or I'm flipping through notes and all that.
And then the next time they come in, I've forgotten it all already because I probably forgot before they got to the parking lot, to be truthful. But it's difficult to do it that way. That's why we've made it a little bit easier. This is probably one of the features that I like the best about DS3, because our goal, Rich, is at the end of the consult is for them to say, "Hey, can I have one of these?" And we evaluate them and say, "Good news, you can. Congratulations." And then they ask the questions that most dentists take. How much is it? And
how much does my insurance pay?
And how much does my insurance pay? And, let me just, as an aside, dentists, that scares them when patients ask how much it is. And I've talked to salespeople, and when someone asks how much it is, that's an exciting question. That means they want it.
That's exactly right.
If you're selling used cars and the guy says, how much is the 1972 Pacer? The guy's like, man, I'm going to get this thing off my lot. I can't believe it. The guy wants it, People don't know I'm way old apparently, but so don't let that be something that scares you. It's exciting, but they're also going to want to know about their insurance, and the instant eligibility check is just a way to quickly evaluate whether they have insurance and what their coverage is. You can do this without DS3. DS3 is the click of a button. You got to get on the phone and call. But I suggest someone does that or work with a third-party biller to find out what their insurance benefits are before you get to that point in the consultation where they say, hey, how much is it? Because now you've lost them.
Yeah, now I've got an answer, Guy, and I know. So when we click that button in DS3, it shows me what their deductible is in network. It shows me what their deductible is out of network. It shows me how much is remaining. It won't give me the maximum allowable. We already figured that out because we would just keep raising that. And as long as they said yes, we'd keep raising the price. They won't give us that. But now we can say, okay, we know that your deductible's this. Here's your copay. Here's your co-insurance. So we do whole webinars about how to present this to patients and what have you. But you got to start with something. And this gives us something to start with.
Right. So we have all that information. We've gone through with the patient. And I know, Rich, you probably do this slightly different than I do. But, you know, I'm not going to just read the slide to you. You can look at it yourselves. But the bottom line is we want to go through the treatment alternatives with the patient, evaluate them, evaluate what their goals are, and discuss how bad their apnea is with them and why that matters, and talk to them about what the treatment alternatives are and whether a dental device will work. There's some other bullet points underneath there you can read, but that's the bottom line. And you know, when I say we need to do that, a lot of that can happen from your team. My team does most of this. Rich, is there anything that I don't have on there that you do? Or do you want to expand on?
Well, one way I say it, Guy, no, I love what you have here. I think that's very good. One thing that I say is, Guy, has anybody ever explained all of the numbers from your sleep test? Do you understand what they mean? No, I don't have a clue. Yeah, I don't have a clue what they're talking about. Well, we're just looking at how many times you quit breathing and your oxygen drops and things like that. You know, you don't have to use big words. You don't have to say AHI, RDI, LSAT. You know, so we do that. But I would encourage you to do this type of thing, what Guy has put there in this very well organized slide, but do it in a way that's understandable. You know, don't try to talk over their head. Make it, you know, as friendly as you can. You know, we just quit breathing, and you know what happened. What I like to say, Guy, is you go to sleep at night and your airway closes down. Your brain has to make a choice. It has to decide: do I want oxygen or do I want sleep?
Yep.
What does it choose? You know, if you're sitting here talking to me today, it chose oxygen. So now your sleep gets disrupted, and then that creates all of these other things. So you got to put your own little twist on it, but don't get carried away. Don't talk too much. Make sure the patient understands it. And when they say, how much is it? You know, I say, Catherine is going to come in. She has all of that information for you. I am here to help you any way I can. I stand up and shake their hand. I say, I'm so glad you're a good candidate for this. I look forward to working with you. And then they come in and do that. And then what do we do next?
Yeah, I mean, hopefully they say yes. We're going to schedule them an appointment, and if you've done everything, and I know we only have an hour here. If you've done everything that we've gone through, you're going to get most patients to say yes to treatment who are good candidates, because there's patients who aren't good candidates. We get better than 3 out of 4 who are good candidates to say yes to treatment on average. So they're going to begin treatment. Well, this becomes the easy part. We've got to do a little different exam, and we could spend an hour on what that exam is. The DS3, there's some screenshots from our cloud-based software that just kind of walks you through evaluating their airway. We're treating an airway problem. If you're treating a dental problem, you should have in your notes somewhere what's wrong with the tooth. If you're treating an airway problem, you should probably have in there what's wrong with the airway to justify your treatment, especially if you're going to bill medical insurance. So there's things that you're not used to looking for, maybe like tonsils and a thing called malapatia. I don't think we have a slide on, and we look at their anatomy in a little differently. Look for narrow arches, retrognathia, mandibular tori, uvulas that are misshapen and elongated, and inability to breathe through the nose, and the joints a little bit differently, all with the idea that we're going to look at their airway, what could be affecting this problem, what could be affecting the treatment we're going to do as well. because they can't breathe through their nose and they've got a bunch of joint and muscle problems, though that may be something we want to be a little bit concerned about as well. So that's the exam. And, it sounds, as I just said, it may be a little complicated to people who haven't done this. It's really just checking off check boxes, and it takes about 6 to 7 minutes in my office on most patients, and it's something I absolutely do myself. But because we're organized, it's rare as it over 10 minutes.
Can I add one thing there on the TMD
Absolutely.
stuff, Guy?
Sure.
If you go back one slide, don't let this scare you away. Remember that most patients who have TMD problems, issues, they get better when we put them in a mandibular repositioning device. So my advice there is simply document what's there as best you know. If you're in over your head a little bit, you should probably ask a colleague, or again, who you're going to call. We like that. I've been trying to get Guy to play the Ghostbusters theme for years now, but he just won't do it. We can be those people that you call, because we do online study clubs and we do things like that. But the bottom line with that is, don't let it scare you away. Be smart about it. Just document it and understand that most people get better.
Yeah, and Rich, you've been taking bites all the way back to when you're using tongue depressors, and what do you use now mostly?
I like the Pro gauge. We use the George gauge, the Ander gauge, airway metrics. I can still do it with the tongue depressor, Guy, if you want to know.
Okay.
Just hand me something. Give me a little bit of goo and something, But we're basically, you think about, I'm going to open and move my jaw forward. What is my range of motion? These types of gauges, your top teeth fit in one groove, bottom teeth fit in another groove, and then I get to see. So it's real easy for me to document. I say, hey, the range of motion is 12 millimeters. We took a bite at 4 out of 12.
At a certain vertical.
And a certain vertical, right, because they come in different. So the Pro gauge comes in 6, 9, and 12. The George gauge comes in 3, 2, and 5, I think, or 3 and 5. So remember, you got to have enough clearance back there. But taking a bite is not hard. You should already know how to do that.
And one thing I don't think we've mentioned, you could go to our YouTube channel, Dental Sleep Solutions on YouTube. All of these videos that we do publicly, we archive there. We've got our videos on dental devices and in bites and things like that. And so this is more of a high level overview of the steps needed, but we go into detail to many of those. So you can go to our YouTube channel or type in consultation if you have a specific question that we're not getting to tonight. The delivery, this is probably the easiest part. If you take good impressions, you take a good bite. I know, Rich, you just kind of hand it to them most of the time, don't you? And say, put it in. I think I usually have my team puts it in their mouth and tries it themselves. But I think, don't you just have the patient put it in? I think you told me once.
Here, try this in. It's yours. It's got your name on it. Look, right here. I don't mind them struggling just a tiny little bit with that kind of stuff. So, don't take a little old lady and confuse her and make her mad, But again, don't be scared about this. That's what Guy's saying. One thing I've learned from Guy is he doesn't do anything, man. He just goes, hey, Brandy, can you do this for me?
Mm-hmm.
Can you do that? He's the master at delegating, but he's able to do that because he takes the time to train his people well. So you got to remember that. You can't just go tell Brandy to do something and you never shown her how to do it. Take the time to show them how to do it right, and then you can delegate it. Now you can come back in when you deliver it. I like to put my fingers on there. Hey, it should be comfortable, should fit tight. But we get through that process and it doesn't take long.
It doesn't. We'll make a repositioner for their jaw to go back in the morning. Again, there's a whole video on that. And so we're going to see our patients typically about 3 weeks later. And we already had this discussion. They better be wearing the device. They can have a problem. They can call us and come back in. But if they're coming in 3 or 4 weeks, 2 weeks, whatever you want, we usually like to give them a period of time to wear it. Are you wearing it? And if no, then first of all, we're going to say, why didn't you call me? You should have come in. Or if they say they can't wear it for some reason, they just called us, then we're going to make those adjustments. I don't want to spend much time on that. That's something that you as dentists can readily do. But assuming they're wearing it, then we're going to go backwards. Go down the list of the 1, 2, 3 that we went through for our goals in the order that we do, which is the CPAP, as we mentioned, goes backwards. You're wearing it. Step 1. Goal 1 achieved, right, Rich? That's number 1 on our list. Check. Number 2, is it working? Well, how would I know? Well, we're going to show you in just a second. If it's not working as well as those 2 or 3 things you identified that they wanted out of it, then we're going to have them move the device more, or we'll move it for them. or you can move it, different amounts depending on the device, and you can do it over a period of time. And then we're going to have them come back in, or we're going to call them on the phone many times and say, is it working again? And we'll show you the system for doing that in a second. And if they say no, we're going to have them move it more forward until we get to the point. Most of the time, these things work. Most of the time, the symptoms get better, or the patient says, I don't feel like I can move any more forward. Once it gets to where we say yes, then we're going to follow up with some form of sleep test to make sure we get to the goal number 3, to make sure it's done well. And here's how we do this. I think this is where we really shine and make life a lot better for our members. So you remember this. This is the patient when they came in, all their symptoms. What's that button do there, Rich, if I click it?
Yeah, so if we click that, we now have a patient who's worn their dental device. They're coming in for follow-up 3 or 4 weeks later. How many nights are you wearing it? 7. They fill out the Epworth and the Thornton snoring scale, so I know how sleepy they are in the snoring from their spouse. And then we go, oh, look at that. Your snoring has gone from a 9 to a 3. Your energy level's gone from a 3 to an 8. Sleep quality's better. Man, it sounds like you are doing really well with your device here, John.
Yeah.
So now I have to make a decision about, do I want to adjust it a little bit more or that? So we got to use our brain at this point. But I have a tool here now that keeps all of this data and all of these follow-up visits very well organized.
Yeah, so we do the same thing with the sleep test. So once the patient, and I'll back up for a second, we could have 2 or 3 columns here. The patient may have gotten better, and eventually where we are. But we do the same thing with the sleep test. And we can do one-night sleep test, or we can actually have them do a home sleep test in multiple positions, go a little further each night, kind of more rapidly, and then back it up after the last night. And we can see at a glance the baseline went from almost 30 events an hour all the way down to 6. And we look at oxygen readings and some things we don't have time at this high level overview to go into. But the bottom line is you need to have a way to look at the baseline sleep test and follow-up sleep test in order to see how well the patient has improved. And if these were 3 pages long each sleep test, and we were trying to lay those out across our table, we'd have 12 pages of paper there that we're trying to look at. So you've got to come up with a system to do this more quickly, which is what we've done. And on top of that, this information goes into letters that are automatically generated that we will send out to our physicians. So assuming that was our patient, the symptoms went from where they weren't happy to where they are. The sleep test results went from almost severe apnea down to mild to none, and we're going to leave them at that last spot. We're going to get them back in about 6 months to evaluate them, make sure they're stable, and then about every year. And this is what I do on these appointments. Rich, you want to talk about what you do on the 6-month and/or annual evaluation?
I see what you have here. I like the clean device because most of the time they're dirty. How do we clean it? We put it in a baggie. We put some tartar and stain remover, zip the baggie. We put it in our ultrasonic for 10 minutes. Man, makes them look brand new. The only thing I might do here, Guy, is I might have them put the AM aligner in for me, and I want to kind of verify that we're recapturing their bite. One of the questions we had from Dr. Coolidge was, how do you get them to wear their morning aligner? And I said, I'll let you know when I figure it out. You know, that can be a challenge, Marie. Yeah. But I say, look, we're dentists. We don't like your bite to change. You don't want your bite. You don't want your bite to change. It is the single best tool we have to do that. So I love what you have there, Guy, too, about evaluate for new device. So remember, a lot of insurances will pay for new devices at about 3 years. And even if the device is okay, it's starting to get a little bit grungy, man, your insurance will pay for a new one. Oh, I had knee surgery too. I met my deductible. Well, your out of pocket will be less. Maybe it's a good time to get one. It's always a great idea to have a backup, in case something happens.
Yeah, so we get through that appointment. I agree with the evaluating the device and do it with the AM aligner. Once we're finished with treatment, we need to communicate with them. One of the things that information that's in DS3 is with the click of a button, and even automatically it goes into letters. You have to send them some sort of correspondence letting them know you've treated the patient, what the outcome is, and what their disposition is. They're back to you for regular medical care, and we're going to see them once a year. So working with the physicians is key. Writing these letters is key to not only doing this the proper way, it's a great way to generate new patients via medical referrals in the future. So we basically send them to all the physicians, and for each of the treatment steps, or at the very least every 6 weeks or so, if the treatment gets to taking a little time, at the beginning of the treatment, the end of treatment, and then in between is where we want to send those. And here's just kind of a screenshot showing how easy that is. You click on the letter that you want, and you can hand type these and do templates, and there's other ways of doing it the way we used to. It's just going to take you a little longer to do that. So we're getting to the final pillar here, Rich. We got about 6 minutes to finish up, so we gonna go through.
Right, I'll quit talking.
That was my cue. To try to get finished on time for everybody. But I think really we don't have to spend a lot of time on billing, because we have, gosh, I think we have over 3 hours of individual billing topics that we've done this year alone. I mean, from Medicare to out-of-network billing to overview of billing. So it's a 3-hour topic plus, if you really want to get into it. But I think the bottom line is here, this is medical billing. If you're going to do a dental device on an apneic patient for their airway, you're a dentist, you're allowed to do that. We'll talk about that the next time, about what you are and aren't allowed to do, and what our opinions and really what the facts are and some of that. But you aren't allowed to bill dental insurance for it, because it's a medical insurance, medical procedure, and the medical insurance should be billed. And so my point on that would be that if you're used to doing dental insurance, you may be used to doing all this stuff on here, root canals to extractions, to doing cleanings. But when you look at these things, are you used to being your own attorney or building your house or flying your own plane? You might better off try that than being a medical billing expert. So you're going to need to hire a medical billing expert if you want to really do this properly, or don't deal with it. And again, we can talk about medical billing in length or YouTube videos.
How much would a third-party biller charge, Guy? Is it real expensive?
No, I mean, most of them don't charge you their percentage unless they collect, first of all, and so they got skin in the game. They do charge a fee typically to, at least if you don't have instant eligibility check, to run that, and also to do a pre-authorization if needed. There's usually a flat fee for that, but it certainly is worth doing, because once you get set up with them, they want to collect your money as much or more than you do. This is an adjunct.
That's how they get paid, right?
That's how they're living. That's how they're making their living. This is an adjunctive income to us. This is their income, so they have a strong motivation to collect the money on that. So these are the insurance decisions that you'd have to decide. Or you want to be Medicare or in or out of network, what billing decisions. But I think for the high level webinar we're doing today, the bottom line really is that it's a medical insurance billing, and you need help, and we can talk about that more in detail in our past and future webinars. So I did want to take a moment to discuss our symposium that's drawing closer and closer. I'm genuinely excited about it. It was a great time last year. Rich, I know you are as well. You're bringing like a lot of your team, right?
Well, depends on how much the flights are. No, my team's so excited about coming. They're excited. I've come from San Antonio. We're going to go to Florida. Yeah, we're bringing our team.
My team will be there.
I think sometimes as dentists we underestimate how important that is to include our team in some of the continuing education that we do. I think it's most important, Guy, for dental sleep medicine, because dental sleep medicine requires everybody to be on board. If everybody is talking it and everybody understands it and everybody knows it, it kind of seeps through, all the way through the carpet and the chairs, and, pretty soon it just all kind of makes sense, and it all starts to kind of come together. So we hope at the very least you as a dentist will do that. We're very down to earth, implementation oriented types of topics. And if you can bring your team, I'm sure that they would love to come as well.
Yeah, and it's it's in Clearwater, Florida, at the Hilton on the beach, and it's a really nice facility. We had almost 300 people there last year. The rooms, we have a fantastic room rate, which is they're really close to selling out on the rooms that we acquired at the discount. So if you want to register, in particular, get your room. You can't get the room unless you register, of course, but get on the room if you're going to want one of the rooms, because they will be sold out by sometime the end of the year, if not by the first of the year. So, and again, look at all those people that are coming, and the fees under $500 for a day and a half, and it's just a fantastic thing.
Good stuff, man. Good stuff.
Yeah, it really is. I'm bringing my team. That's going to be exciting. This is what we do at DS3. We help with the 4 pillars, which are screening, testing, treating, and billing. But, there's a lot to that. We have a whole educational team that can help you everywhere from videos to live in-person dental sleep trainers that come to work every day. That's their job, is to help. We have individualized and group coaching. Our DS3 software we've mentioned over and over again, which streamlines everything. And then we have support. We actually have webinars. Rich and I do a couple of webinars every other week. One of them is just for DS3 members, where they get to talk and interact with us. Not that I don't enjoy this, but I really enjoy that, because it's kind of I learn a lot. We have a lot of interaction with our members all across the country, and all kinds of other support, from Snoozle, which is our dental sleep search engine, to again, our team that are ready to help you. If you want to know more about what we do, or if you just have a question, go ahead and type in consultation. We'll give you a free consultation, and we can, I guarantee you, help answer some of your questions that you might have. So
very good, Guy. I think we've done most of the questions there. Again, it doesn't take that long to do. The return on investment, even after you pay us, you only got to make 1 device a month to pay for us for the entire year, just about. But, Guy, I don't think it's unreasonable for a dentist who doesn't know anything about this, that within 6 to 12 months can be doing 1 dental device a week. And if you take 4 weeks off, that puts you at 48 dental devices. You're going to collect 120. You can do the math there. So this is a good thing. It's the right thing to do. It's very rewarding, and you can actually get paid for it. So there's nothing wrong with any of those things, is there, Guy?
No, and I'm going to mention that I think we're very conservative. I'm always in the mindset of under promise and over deliver. So I think we've set reasonable amounts for what you can average per device. We've set a reasonable lab fee, and we've included third-party billing fees in this, and we've even included DS3 fees in this return on investment. And 1 a week is a very conservative amount. You're pushing 6 figures. You're over $90,000 at that very conservative rate. So we have the system for you. Again, type in consultation. Here's our phone number if you just have a question. It's easy to remember, 877-95-SNORE. The next one, again, will be 2 weeks from tonight. I think it's 2 weeks from tonight, December 12th, whenever that is. Yeah, it's 2 weeks from tonight. And again, we're going to talk, it's a subject we haven't really, there'll be some overlap. We're going to really kind of try to talk more about specifics about what we can and can't do, and what works and what doesn't. So I think it'll be a little different than what we've done in the past. I'm sure we'll have a ton of questions from that. So mark your calendars for that. And last thing, we want to give you something for free. If you're not familiar with the Don't Sleep Insider magazine, there's the website where you go. We have one coming out next week. It is a free dental sleep digital magazine that comes to your inbox. Rich writes wonderful articles for it each time because he's a great writer. I'm not a great writer, so I do a video for each month. But they're practical stuff. What's yours on this month coming up? Do you remember? There's so many of them. I know what mine is. I think mine's a video on a dorsal device. Sometimes you run out of advancement because it only goes 5 millimeters, and I show you a technique of adding acrylic to the distal of the wing. It takes about 20 minutes to the video. It took me about 30 because I was filming, and that's something you could teach your team to do, and it's a great clinical pearl for dental sleep. So again, that's what we do, and I was going to put up the expert sign saying you all are becoming experts if you're joining us each week. I think we got finished almost on time there, Rich. Not bad. There's our contact information. Unless I know you've been looking at the questions more than me. I know our team's been looking at those. Do we have any questions we need to answer here?
No, we're good. I think the morning aligner one, some people are talking about, hey, we're getting close to the end of the year. you got to make sure that you're signed up with these insurance companies and stuff. That can take a little bit of time, but once you do that, if you've got that done, if you're not dealing with insurance, man, make them a dental device. I don't care what day of the year it is, and we don't have to do insurance. We have to remember that it's a service that we offer to help our patients say yes to treatment. So I think you covered it, Guy, man. As always, you do a fantastic job putting these things together. I appreciate that.
Well, thank you. Sorry I rushed you there a little bit, but we try to stay on time here, which we're cognitive of the fact that you all are away from your families, or at least your attention's away from them, and taking the time in this evening or early evening or later evening if you're over in the East time zone as I am. Thank you for it. I hope that it was beneficial. And again, if you need anything, don't hesitate to reach out to us. I think you'll find that everyone at the DS3 team is knowledgeable and just willing to help, even if it's just answering a question. So have a good night, and we'll sign on again in a couple weeks and talk about something new.
All right. Sounds good. We'll see you guys.
All right. Bye-bye.